And our next speaker has come all the way from Germany, and that's Thomas Kühn. Welcome. You're a neonatologist in Berlin. And you are also working at a company with neotraining. And you will not talk about the golden hour, but you will talk about the bonding hour. So please go ahead.
Thank you very much for this kind introduction, and thank you for inviting me to this conference. I have to use my own computer due to some technical problems. Normally I like to move around during a speech, but now I'm nailed here on my PC, but it works, I think. And I hope you are not too tired in the end of the day. Is anyone sleeping? No. Let me ask you first two questions. Is NICU care and separation from the parents a stressful and traumatic experience? Yes or no? And if we would call it stressful experience in other conditions, we would call it an adverse childhood event. And if you imagine a preterm is spending sometimes up to 2 months, 3 months in an ICU, it will be a long adverse childhood event. And the second question, if we accept it, if so, what can we do against it? Let's first have a look into the back. We heard about that. Parents as visitors, parents behind a sheet of glass. Did we provide brain protective environments in the past? Are we avoiding traumatic experience in the past? And are we doing family integrating care? Is that still an utopia? As I come from Germany, I always look into Sweden, to the Karolinska and the other hospitals as a lighthouse. So we are mainly far away from that. And when I do visiting Romania, we heard that from Bulgaria a couple of hours before, there are still parents far away from their children in the unit. I saw that in Bucharest, they bring the more healthy term babies out of the unit to be breastfed, and the mother is not able to go inside due to some infection cautions. Klaus and Kennel, two pediatricians from the States, asked us early in the 70s, does the obstetric and neonatal hospital culture probably causes lifelong disorders of the mother-child bond? I would modify that a little bit. You heard that from Silke Mader. Also the fathers are suffered 26 years after preterm birth from bonding experiences. This is a video I found in the internet. A British ward. You can be happy if you get your own child back, as it looks. Yeah, it's some decades ago, but no one was looking into the mother-child interaction, into secure bonding. A lot of things have changed since then, but are we providing healing environments, and are we providing secure attachment behavior between mother and child, between family and child? And this is a slide, I think it comes from Heidelise Alts, an American NICU in the 50s or 60s. It looks more like a car production company or something like that. But this is where we come from. And later on it changed a little bit. We had a little bit smaller units, but in most of the NICUs in the world we are far away from the Swedish styles of family rooms. And we have to accept that there's a huge discrepancy between the environment, such an environment, and the needs of a preterm infant. The brain was promised for sure another surrounding, another environment. And Heidelise Alts asked a question, a more philosophical question, and I like that question very much. Should we make the person fit for the environment, or should we make it the other way? Should the environment has to be adapted to the needs of a person? This is not only for neonatologists a task, I think is for all hospital care, for all medical care, a question. we didn't change so much worldwide. This is the most modern unit in Beijing, in China. They now have the money, they now have the technology, but they do the same old mistakes as we did 40, 50 years ago. Individualized care in such a setting, brain protective care environment, I don't see that. But let's go back to the fetus. This is the normal natural plan. Staying 10 months in utero, mother and child always together. And then preterm birth occurs much too early. Normal length of pregnancy is 268 days. Sometimes we have now 22, 23 weeks in our resuscitation tables. And preterm birth, in my opinion, and separation in an NICU is for sure a traumatic experience for the mother as well as for the father and also for the child. And we need psycho and physical closeness, and we have to change our NICU attitudes, and we have to change our buildings. And if you look into such an immature preterm brain, this is a brain from a 24, 25 weeker. You can call it mushroom if you want. What does injure a preterm birth at that early stage? We know a lot of things. Born too soon is the key factor to harm a brain. Long-term intensive care, long-term ventilation, infections, bleeding, you'll know all of this. But also pain and stress, and also fluctuations in some physiological parameters like PO2, PCO2, or blood pressure. This is normal knowledge for everyone, but are we aware that postnatal stress, postnatal separation causes trauma and stress? And we heard that in the morning. This will increase our corticosteroid levels, and it will, on the other side, decrease the protecting endogenous endorphins. And Niels told us in the morning, it's all about resilience. And this will lower resilience for sure. So the consequences, as a consequence, there is to see in specific vulnerability, mainly in the limbic system, in other central regions of the brain, amygdala and so on. And this is the most vulnerable time frame for the developing brain in the last trimester of pregnancy. And this trimester of pregnancy is in our hands now, in our NICU. And if the brain isn't developing in an adequate, normal way, we lay the basis for abnormal psychology even in adulthood. We see changes in the tolerance with stress, we see changes in the capability of affect regulations and attachment and relationship with behavior disorders. So if we accept all of it, this is question 2, what can we do against it? What is the status quo? What kind of children we are expecting when we are called to the delivery room? Normal newborns, okay. Newborns after C-section, in Germany, every 30% C-section rate. In some areas up to 50. Quite often some kind of respiratory maladaptation, we call it wet lung disease. Some children are infected. We see late preterm infants. That's the majority of preterm birth. We see babies which are small for gestational age or large for gestational age. And more or less we see very low birth weight or extremely low birth weight infants. And also sometimes some newborns with congenital malformations on the heart, on the stomach, wherever. But all of them should have a chance for immediate bonding with their parents whenever it's possible. And I think in the main time it is possible as long as the baby is not resuscitated. And I will show you how we started. And we are learning from the group from Cologne, and Katrin will present after me. Can you reduce a little bit the sound of the video? Thank you. I'm just a guy who is working in a community hospital. We are not doing so much research, so I'm a profiteur from the studies others are doing. You see that here. It's approximately 8 years ago, and it was my first tiny preterm putting on mother's chest. You see, the father is sweating, and I was really nervous that the baby could cool down and they will kill me later on in the NICU. But in fact, I have to switch off the second radiant warmer, and the first one was reducing himself via the servo control mechanism. So I think it's very important that we should use this early sensitive period where we have a maximum peak of oxytocin, because that oxytocin will facilitate maternal behavior as well as has anxiolytic effects and also sedating effects for the mother. 2 weeks ago in our unit, now it is standard therapy for us that nearly every baby, regardless of gestational age, is putting on mother's chest. You see here twins, 28 weekers in CPAP, high flow CPAP, bonding right in the delivery room for 35 minutes. We had a learning curve. We don't start it with 24 weekers, but it is possible also. And there is no pressure for us. If the mother decides not to have her baby on her chest, we try to create other policies for bonding, and you see that in this picture here. They decided to have the baby just side by side. So put mother's bed on the same level like the resuscitation table and give them a chance to come into a close relationship. It works also for very tiny babies. You can see here 380-gram baby on CPAP after LISA surfactant application. The normal transmission period in our unit takes approximately 35 to 60 minutes, and after that we bring nearly every baby on mother's chest. It works even for the smallest infants. I feel that it is essential for the establishment of a secure attachment behavior, not only for the mother, as you can see here, father is more proud than her. I think it's very important to imprint the child's microbiome, because if the baby is born via C-section, it comes nearly completely sterile onto our unit. And someone mentioned it earlier, it is a milestone for inducing the lactogenesis, because without oxytocin, without prolactin, you can forget continuous own mother's milk feeding. I said earlier we have also children with congenital malformations in the DR, and this is a child with an Omphaloceler, and you can see where the silo. This silo will be there for approximately 1 or 2 weeks before the surgery can be done. And I think it's very important to bring also those children on mother's breast whenever it's possible. 5 years ago, it was the first time that we bring a newborn with a diaphragmatic hernia on mother's breast, even in the GR. Surely this girl was immediately intubated and got on high-frequency ventilation. But after 30 minutes, we saw that she was very stable, and we were thinking about putting her on mother's chest. And I remember as the surgeon came to me and asked, "Where is this baby?" And I said, "On mother's chest." "Are you crazy?" Last but not least, I have 3 minutes time. I will show you the story of Lily, 25-weeker, C-section. You see here my colleague is sitting right in the DR for a late cord clamping. And she gets on CPAP. We work with very high CPAP levels like the group in Cologne always do. Comfort position, light dimmed. And then it's it helps me very much to calm down for myself, to take a seat, sit down and wait until she is adapting slowly. She's now 16 minutes old, and this is the earliest time frame where we start to put an IV line in. Take the normal things, blood probes, blood gas analysis, and so etc. And then father is there to welcome his daughter, and also you will see it. The nurse is very hard stuffing. He has to assist her in the job. Ups. Muss ich machen, ne? Warum läuft's nicht? Muss ja. He's very nervous, you can see that. Yeah, there are so many things to do, and we like to do it in a quiet atmosphere with less people in the room. Microbiological swabs, blood pressure, and father is already there to support his daughter. So and then we stopped laying the baby in the plastic bag. We remove always the plastic bag, even a 25-weeker. She's going in her new nest. I don't know why it's stopping. Okay, I will hand over. Question is, after we are finished, which way we should choose? On the right side to the NICU or in the left side to the mother? And we decide in 90% of deliveries now to go to the mother. There's an additional radiant warmer to prevent hypothermia. She didn't get any surfactant, there was no need for it. She's only on high flow CPAP, room air, and then we put her on mother's chest. And then she stays there for sometimes 30 minutes, sometimes 1 hour. Sometimes we have some organizational stressors, like the midwives is calling us, the mother has to be removed out of the room because the next pregnant woman is there. But normally it works at least for half an hour or 45 minutes. Okay, last slide, summary, take-home messages. I think that stress around a birth, pre, peri, and postnatal can cause early adverse experiences, and we should avoid that. The early NICU care experiences might be protective or might be harmful. This is mainly in our hands, and they could have long-term impact on cognitive and behavioral outcome. Caregiving support and also the parental sensitivity are essential for long-term normal outcome, and the parental sensitivity stays, in my eyes, very high. Early bonding is the first step to create sensitive parents. It reduces maternal and child stress, and what I see in my unit is that mothers who had experienced early bonding, they are not so afraid touching a baby, taking the first kangaroo steps later on, because they feel that they had a child and it was safe and secure on her chest. Family integrating care starts before preterm delivery and must continue through all the care process. Thank you very much for listening.
Thank you, Thomas. That was really interesting and amazing to see. Yeah. Any questions to Thomas?
None.
In what phase do you put the lines in the umbilical arterial?
I know that there are different strategies in the units. Some say it might be minimal handling if you put central IV lines right in the umbilical cord. We do that not very often. We do that if the baby is resuscitated, is on heavy ventilation mode, and I see that as a very immature and sick baby. We try to start mainly first with peripheral lines. Yeah. In the 380 gram, we would put central lines in because there are some technical issues. Yeah. Yeah. But if I see after 2 days that we often have to change and replace the peripheral lines, and we can't induce the enteral feeding very much as we want, and we need central lines, we will switch over after 1 day or 2 days to a central line.
Any other questions? It's really fascinating to see these small babies adapting on the mother's breast. Yes, please, Sophia.
It's a wonderful presentation, very inspiring. I'm wondering who decides, is everyone working the same way in your unit, or who decides if you're going to go skin to skin after primary stabilization?
As we implemented that, I think it's very important not to make that a top-down process. You have to include, as you mentioned earlier, the whole group. And we discussed it with the nurses, with the midwives as well, and also the doctors. And this group making standard operation procedure, and this was then finalized for the whole team. And now it is an obligation to put the baby on the chest, and if someone is not doing that, he has to have good reasons not to do it. Yeah? There are always reasons not to do it. Sometimes the mother is too sick, sometimes there is not enough staff in the unit, and I'm often asked who is observing the baby, who is looking for security and safety. I must say, if the baby is born at 2 a.m. in the night, I will sit there, because I know there are less nurses in my unit. Nobody has time to sit close to this baby. So I come into the hospital anyway, so I can sit 1 hour more and watch over for the baby.
Good point. Well, the doctor.
Yeah, and another argument is what I often hear is we can't do that because we have not enough nurses and so on. And the question is, you are going for outpatient transportation, and in that situation, a team is 2 hours away at least from the unit, and the unit has to organize the workload during that time frame. And how often is really a sick preterm born at night per year? So I think there are always solutions.
And maybe there is one senior doctor, one junior doctor, and yeah. Thank you very much.